Good morning, good afternoon, and good evening, everyone. And thank you for joining us for this UICC Special Focus Dialogue, Patient-Centered Care at Every Age. Our goal is to start a conversation with you all around how we can better respond to the needs of older adults and those with comorbidities. And as with all UICC dialogues, this session is really about building a conversation with you. And so to kick off, thank you all for submitting the poll. It's really interesting to see what our understanding is like of the burden of cancer in older adults. What I find really interesting is the answer to the first question is actually 55% of cancer cases are diagnosed amongst the over 65s. But it's really interesting that actually over half of you have suggested it's 61%. And I think that's great. It shows we have a really good understanding of, the importance of dealing with cancer in older adults. Pretty much most of you were right. About 50% of those cancer cases are diagnosed in high income countries, and about 50% or 50.2% are diagnosed in low and middle income countries. And you're all spot on that actually over the next 20 years, we'll see coming up to 2/3 of cancer cases diagnosed amongst older adults. So you are all incredibly well informed. So I'm really looking forward to the quality of the discussion that we're going to have with you all today. So this dialogue is being organised on the eve of the International Day of the Older Adult. And it's a really critical and a really valuable time to come together to really explore what it is that we can be doing better as a community to care for older adults with cancer. COVID-19 has shown us the importance of caring for our older adults. The over 65s were nearly 62 times more likely to die from COVID-19. And at the same time, around 55% of cancer diagnosis, treatment and care services have been disrupted as a result of COVID-19. So that's really going to disproportionately affect older adults. And that figure actually jumps to 69% when we look across NCD services. So what we wanted to do today was bring together three really engaging, really well-informed speakers to talk about what we can do from a clinical perspective, a patient support perspective, and a sort of policy advocacy perspective. So without further ado, it's my absolute pleasure to invite Dr. Enrique Soto Pérez de Celis. Enrique is a researcher in medical sciences at the Department of Geriatrics at the Instituto Nacional de Ciencias Médicas y Nutrición, Salvador Zubirán. And Enrique, I hope my pronunciation was not too poor there. And we were also absolutely delighted that Enrique is also a young leader for 2021-2022. So Enrique, I'd love to sort of kick off the conversation with you, if that's okay. And how is it that you think we can start to develop people-centered clinical services, and particularly in more resource-limited settings?
Hi, Rosie. Thank you for the invitation. I'd like to thank UICC and thank everyone for being here. It's a real honor, and you did a perfect job with the pronunciation. So, as you said, I'm a medical oncologist. I work in geriatric oncology at a public hospital in Mexico City. And one of the questions that we had is, how can we build people-centered geriatric oncology globally? And as you showed nicely with the poll questions, cancer in older adults is highly common, and it will become more common in the future. But to me, one of the main issues is that cancer outcomes depend highly on age, on chronologic age, and on geography. So the incidence to mortality ratio of most cancers, cancer-specific mortality, increases with age. This does not mean that people are dying of other causes but of cancer, and it changes depending on the continent in which you live. So if you live in a low and middle income country, you are more likely to die of your cancer than if you live in a high income country, and this is even more so for older patients. So this shows us that we are not providing the highest quality clinical care for older patients, and that it is necessary to provide geriatric-centered care. The International Society of Geriatric Oncology, SIOC, recently published the priorities for the global advancement of care for older adults with cancer in the future. And two of the things that were highlighted in that paper, which was published in the Lancet Oncology earlier this year, was the importance of developing clinical models and of improving access to care through resource stratification. One of the main barriers for the implementation of geriatric oncology and of patient-centered care is the lack of personnel. So there is a limited availability of geriatricians and of personnel with geriatric competency. In the US, for instance, more than half of geriatric fellowship spots remain empty when they choose their specialty. It's not recognized as a specialty in many countries. It's about 41% of countries recognize geriatrics as a specialty. So there are high limitations in the number of personnel that's actually prepared to assess and intervene in older patients. And there are very few specialized units. So there are a handful of geriatric oncology units across the world. I think that there are 4 things that are very important when planning to start a program. One is assessing the needs of your country. The other is choosing the best model of care, and that depends on the available human and financial resources, and then tailoring the assessment and the interventions to your specific population. One of the first things to consider is the age limit. So either a chronologic age does not exactly represent functional age, and the definition of an older adult varies across the world. So while in some places in Africa, it can be 50 years when you become an older adult, there are other places where this is much higher. And another point that is important is choosing the point in the disease trajectory. So should we be doing this before the start of treatment, at the end of treatment, a part of survivorship care? And that highly depends on your resources and on the life expectancy of your country. We developed a series of recommendations from SIOG as well, was published in 2018 in Journal of Oncology Practice, trying to do some resources stratification, because I think this is important. Most oncologists in the world work alone, so they do not have a geriatrician or a geriatric stream. And I think that in these settings, the use, for example, of screening tools that can help identify which patients are more likely to benefit from a full geriatric assessment and intervention is essential. And if you have a larger hospital, then you can have a multidisciplinary team in which you can have someone like a geriatrician or a nurse that has geriatric expertise. At our center, we have created a geriatric oncology clinic in which oncologists, geriatricians, rehabilitation technicians, and nutritionists work together to provide care. And this is one of the first oncology clinics in Latin America. Another important point is tailoring assessments and the delivery of clinical care. So, for example, I always use this example. If you ask someone who lives in Barcelona or in Milan if they can walk a block, this makes sense to them. A block means something. But if you ask someone who lives in a small rural village in Mexico or in Guatemala or in Asia, if they can walk a block, this may not have any meaning at all. So we do have to be mindful of the cultural and social circumstances in which we live and tailor our assessments and interventions. Support from leadership, we're going to talk about that in the future. That's another very essential part, because we do need infrastructure for this. We need personnel, we need space, etc. So in summary, can we today implement geriatric oncology in resource limited settings? Yes, it is extremely necessary. And I think we are highly motivated, as this dialogue shows. There are many models of care, and we can discuss how to adapt them. This represents a great opportunity to interact with other disciplines and other specialties who are also interested in providing care for older patients, and also opportunities to innovate and improve access to care, for example, through mobile technology, digital technology, big data, etc. And I do believe that geriatric principles should be included in the shared decision-making process for all older adults with cancer, regardless of where they live. Additionally, we do need more data. We need data on the effect of our interventions in oncological outcomes, quality of life, function, cognition. The cost effectiveness of geriatric interventions in cancer is not well studied. We need to include patient-reported outcomes into every study we do, and then use strategies to optimize these outcomes. For example, telemedicine in the setting of COVID-19 is a very interesting potential. And in the end, I hope that this can set up a nice discussion in order to meld the fields of geriatrics and oncology with public policy and help improve the lives of our patients. Thank you.
Fantastic. Thank you, Enrique. And I think it's really great to hear from your own experience about sort of working in Mexico, but as you say, the critical importance of making things sort of culturally and socially relevant and sort of tailoring them to the context in which we work. And as a key part of that, really bringing patients into sort of the decision-making and kind of service development and care pathways. And with that sort of in mind, Jacqueline, I would absolutely love to come to you Before I do, it's my pleasure to introduce you to the participants here today. Jacqueline Daly is Secretary to the Board of the European Cancer Patient Coalition, who's a co-sponsor of the event we're holding today. She is the co-founder and director of services at the East Galway and Midlands Cancer Support Centre, and she's a dedicated patient advocate and campaigner who's dedicated to bringing awareness around patient needs to local and national government agencies. So Jacqueline, thank you so much for joining us here today. And I think to sort of kick off the beginning of the conversation, it would be great to hear from you around how we can develop better patient support services, particularly for older adults and those with comorbidities.
Thanks, Rosie, and thanks everybody for being here today. This is a very, very important conversation that needs to be had. I would like to highlight something that sometimes we focus on somebody's age, but we're all very different. And I think we need to take a more holistic approach. At the support centre here where I work, we offer physical activity programs, dietitians, complementary therapies, and whoever walks through the door, the same service is offered to everybody, regardless of what age they are. And I feel that the one-size-fits-all approach is no longer valid. We should not focus only on the age of the person who walks through the door, as everybody has his or her own story to tell, his or her own experience. And if we focus on age, then we're taking away so much else from them. We need to listen to their experience, to the different approaches they have to the disease. The most important thing is to take away the fear of asking for help. And if that means offering counselling services, support groups, each and every patient who walks through the door, no matter what their age are, must feel that they're being empowered and that they have a voice, and that there's a group of professionals here who is offering to help hear them individualize their whole journey through their cancer process. And we need to personalize this support for them.
Fantastic. Thank you so much, Jacqueline. And I think one of the key points that sort of Enrique made, and maybe just to follow up very quickly before we move on to Vicki, is the importance of bringing older adults into decision-making. And from your experience, how can we do that? And what's the role of sort of patient support services within that piece of work?
Well, again, it's one size won't fit all. We have to treat everybody who walks through the door as an individual, and leave that space open and safe that they can actually express. Just because you get older doesn't mean that you can't use your brain, that you don't have a voice. You have a voice, you have a choice, and we have to allow the older person to use their voice and to make the choices for themselves.
Fantastic. Thank you so much for that. And I think sort of with that focus on voice and on choice, it's my pleasure to move across to our final speaker to help set up and frame our discussion for the rest of the session. And our last speaker is Dr. Vicki Pinkney-Atkinson. Vicki, thank you very much for joining us. Vicki is an activist geriatric patient with multiple morbidities from a middle-income country. And Vicki, thank you for joining us today from South Africa. And I wanted to pick up on the point that Jacqueline just made and actually ask you, how is it that we can build the advocacy and policy environment necessary for patient-centered care and bring those voices into the conversation?
Hi, thanks. It's a great question, because you don't get it by sitting on your tuchus, on your bum. You're not going to get there if you don't do some work about it. So I'm going to give you a little bit of my own experience, because we, in South Africa, we have a human rights case against our government for failing to take care of people living with non-communicable diseases, including cancer and including geriatrics. We are a neglected majority. And so it's not just about whether you are in small numbers or big numbers. It's just really about, unless you find your voice, it's not going to happen. So I have had non-communicable diseases since I was born, basically. And I haven't been particularly careless in my life. I haven't done ridiculous, well, I have done some ridiculous things, but I haven't really lived a risky lifestyle. So I have 20 treatable, non-communicable conditions. And I call them conditions because each one of them requires management. In the old days, when I was young in my professional life, we used to call it the problem-orientated medical record. And that problem-orientated medical record took problems of significance and dealt with them. Unlike today, where you get a label, diabetic or whatever, and it's not the problems that get dealt with, it gets the whole disease becomes an ICD-10 classification or something like that. And amongst these, and many of them have been misdiagnosed or not diagnosed properly most of my life. And I was in my 30s, I have psoriasis, which I got as a child, which is rare. And I just started developing the arthritis and all the comorbidities with that illness. And I was terribly ill. I mean, in that age, I was much older than I am today. I couldn't walk. I had to stay in bed. So it's really, I appreciate what both Jackie and Enrique is saying, is that it's about where you're at in your life. If you've given up, then good, that's fine. You can give up. But I haven't given up. I will be 70 next year, and I will then be, I will have actually shocked. I am really shocked to still be alive. And so and I only became an activist for non-communicable diseases 8 years ago because it was so appallingly managed. And I have worked in the care of non-communicable disease patients for nearly 50 years. So it's nonsense. So let's go back to all of these issues. I have nearly died from the complications of my psoriasis. And although I don't have anything like cancer, I have used cancer medication for the treatment of my arthritis, methotrexate. And methotrexate is a ghastly drug. And when you get put on it unknowingly and unwittingly by rheumatologists in huge doses, it kills you. And so I have nearly died of the complications of HIV. So that is, I nearly died of PCP pneumonia. I nearly died of, and that was in my 50s, and I had nearly died of infections, encephalitis and meningitis, etc., etc. So I'm really trying to say here that when we're talking about care, we have to talk about it as if the person also has many illnesses and conditions, some of which have to be treated like in the palliative state. I can't treat my psoriatic arthritis except with pain relief medication, and there's no miracle cures. I will die unless I get reasonable treatment. So what does it take for us to you've got to want to live, and you also got to have a big enough passion to say this isn't okay. And so ageism is really appalling. In our country, there are not that many old people compared to high-income countries. But the people who are older and who are poorer live in rather difficult circumstances, and it's hard to get heard. So what is it going to take? It's going to take not an MDG approach, a Millennium Development Goal approach. We are way beyond that. It's going to take integrated person-centered health services, and there's a whole framework of that under UHC. Well, it's for everywhere. I am so sick of us having silos of healthcare, and even we're going to be treated as a cancer patient and this and this. We are people living with many issues, just the same as you can be happy one day and sad the next day. You can also live, the only condition I don't really have is cancer, you know, but I mean, I've got a lump in my breast at the moment, so maybe I have got cancer, so who knows? So what we need is an all of society, all of government approach. And you can't stagger that, and you can't wait one for the other. You've got to move forward on as many fronts as possible. And I am so tired of people telling me that there is something called integrated care when they run parallel services next door to each other and call those integrated. That's bull. They're not integrated. And so I have had to become a policy expert in my 60s because nobody else would take on the job. And so it's up to you. You can do it. You've just got to, for years I was alone, but now I've got hundreds of organizations and we can do it together. But you've got to want to do it because you can't have your little ivory tower of cancer all on its own.
Come on,
so that's really what it is going to take. Thank you. If it's shoo, I'm sorry if I offended you. Bye-bye.
Thank you so much, Vicki, and thank you for injecting some fire into the conversation. That was very much appreciated. And I think the point you make around whether services are truly integrated or whether it's integration on the tin and other contents inside the can, then I think that's an issue that we've been seeing quite frequently. And I think it's great to hear as well that around the role and the importance of sort of building, older adults taking agency within their own care. You touched on the issue of sort of ageism, and I think it's something that we see across all three sort of domains that each of our speakers represents. So I want to pose a question to all three of you. I'll do it in turn, but in the meantime, I just wanted to remind everyone that if you have any questions, please do pop them in the chat box and we will integrate them into the conversation. This is very much, as it says on the beginning of the event, this is a dialogue. This is about having a conversation together. So Enrique, I'll come to you first. Actually, how is it that we can start to address ageism and ageist sort of approaches within a clinical setting? You mentioned the importance of recognizing that chronological and physical age are very, very different. So how is it that we can actually step away from ageism more broadly?
Yeah, so ageism affects many levels of care. So ageism affects the healthcare personnel, of course, but it also affects society in general and even the patients themselves. So many patients have ageism beliefs towards themselves, and they believe that because of their age, they are not suitable to get treatment or they shouldn't be seen by the same level of care. This happens a lot, and this has been studied across many chronic diseases. So from the clinician point of view, I think that the first thing we need to do is generate data. One of the main problems why there is a lot of ageism among clinicians is that there is a lack of information regarding outcomes about older adults with cancer, and this spreads to other diseases as well. So older adults are seldom included in clinical trials looking at new cancer medications or at new interventions. And then we lack information on how to best treat them. And that makes many physicians just believe that they shouldn't be treated in the same way as younger patients. So I think that increasing older adult participation in clinical trials is one of the ways to stop ageism, providing physicians with more data and evidence to guide their decision-making. Another thing that has to be done is the inclusion of older adult voices into educational campaigns. We need to steer away from this image of the patient with cancer as a young woman with breast cancer. This is very prevalent across many countries. We need to include older faces into advertisements, into campaigns, in order to show the world that these are the patients that are actually living with cancer and living after cancer. And I think that that's one of the ways in which we can avoid ageism. And the other, across the healthcare professions, is including geriatrics into the curriculum. Many nurses, physicians, etc., are not getting any exposure to geriatrics at all. We did a small survey in Mexico across oncology specialists, and many of them had ageist beliefs. And we even looked at whether these physicians had lived, for example, with their grandmother, or they lived with an older adult at home, etc. And that did not influence their ageism. I do believe that intergenerational interventions are another potential solution. So There are a ton of solutions, and the UN recently published a report on ageism that I recommend everyone to read because it's very interesting and complete. And I think that UICC also has a great part to play in that, and that these types of things, these types of dialogue, and including aging into the agenda, leads to a reduction in ageism.
Fantastic, thank you, Enrique. And yeah, we'll see what we can do to pick up that challenge within our own work and within our own communications. I think you picked up on a really interesting point around the fact that older adults may be missing or often missing from clinical education, and so you know, healthcare workers may not realize that they have sort of ageist beliefs. And so I wanted to sort of maybe come across to you, Jacqueline, because I know that there has been quite a bit of progress made in Ireland around sort of addressing some of this, but also to get your take on how we can better integrate older adults and sort of the working age population and younger populations within patient support services. So there's two questions there. My apologies for firing them both at you at the same time, but we'd love to hear your perspectives. I think you're on mute, Jacqueline, one sec.
There we go. That might be better. Sorry about that. Apologies. Yeah, I suppose if we were to bring people into a room and not ask anybody their age, and if we were to assess them all, you might find that the 30-year-old might fare out an awful lot worse than the 60-year-old. So we're lucky in Ireland where we have an assessment of each cancer patient that comes through. And it is on that assessment that the most multidisciplinary team will decide as to what is the best form of treatment for them. So it's not going to be done on age. And we're also looking that older cancer patients, and I'm talking about 65 plus, are not denied clinical trials. So if you're fit enough and well enough to actually have the trial, you'll be given it. Now, I'm sorry, Rosie, what was your second question?
No, don't worry, I fired two at you at the same time. That's entirely my fault. So the second question was around, you know, if we're striving to address some of these ageist beliefs, one of the ways that these are manifested is that older adults are treated in sort of a silo. We'll treat the older adults in one category and we'll treat everyone else in the same. How is it, and does your centre have any experience sort of bringing older adults and say the working age population together, or working across older adults and different generations?
Yeah, again, because we don't judge people as they come through our door. Now, we're a cancer support centre, we're not a treatment centre. So whoever comes through the door will be offered whatever services is here. And I think really it comes down to education. It really comes down to education. And I think this is something that needs to go back to the training of our health professionals, doctors and nurses, that at the very stage of their training, that they realize that I might be 60 and not very well able to walk, and there could be a 75-year-old beside me who has a much higher fitness level than me and would be able to tolerate you know, different treatments better. So I think it does come back to education. It comes back to realize that number is an age, and that's what it is. It's an age, or sorry, number. Age is a number, and that is important that we realize that we cannot put people into boxes. Again, the holistic approach is the best way to do it.
Wonderful, thank you. And for those of you who are interested, we'll be sharing a report on sort of cancer and comorbidities, and there's a small case study from Jacqueline's Centre around sort of integrating some of this care, so you can find out more in that. Vicki, I wanted to sort of come to you. We've heard a little bit around how some services are sometimes sort of cut off on the basis of age, and we've heard an awful lot about how, you know, your chronological age, the number on a piece of paper, actually has comparatively little bearing on how you may live and function as a person. Can you speak a little bit to some of the experiences and some of the advocacy you've been doing around sort of tackling some of these age limitations and rationing of health services?
Thank you. It's a tricky question. So I think if you base your belief system and your healthcare system, as we are fortunate enough to do in South Africa, on human rights and the recognition of human rights, it means that you don't discriminate against any person in particular. And so age is just one of those categories, and people in the aged group are supposed to be vulnerable. Well, you wouldn't notice that by the way that policies get implemented, certainly in a lot of African countries. I mean, you know, I'm not even going to go there, but so really to get back to it is to say that, number one, we have to fight for the rights of vulnerable groups of people. And what COVID has done is to highlight that the aged are a very vulnerable grouping. And it is probably, although I've looked at the stats and all the rest of it, and it's split, but it was evident very early on that it was aging and comorbidities. And so I'm never really, although when they do the CI ratios and things like that, they say that it's independent of all of these things. But the answer is that really, I think we don't know enough about aging, and certainly in low and middle income countries, we are a dying breed. You know, we're going to catch up, I believe, but we are certainly very vulnerable, and we've had to address this through policy issues, demanding our rights, pointing out facts at the government level, because your age is probably the easiest thing to measure, and our government has all of those stats, but they don't have the stats on non-communicable diseases. So it's addressing them, confronting them. And if anybody wants to really get active, I'm going to recommend, and I'm sure you'll put the link in there. It's the UN-UHC report on social participation. Voice, it's really the most remarkable book. It's about 200 pages, 183 pages, and it tells you chapter and verse how to do it. You can't do it alone. That's the secret. So you'll have to find a few buddies along the way. And that's the only way to do it is, and then make it all of government and all of society, and then bring people on board, you know, and that's been the miracle that's happened over the last 5 years has been, we've got 100 organizations joining us in our fight with government to make sure that we get the right care. And I don't care which vulnerable group you're talking about, the principles are exactly the same. You know, you've got to define who the group are, get the evidence, and fight back. You know, that's really the only way to do it. I'll shut up now. Thank you.
No, that's wonderful. There's no need to shut off at all. Thank you, Vicki. And I think my colleague Susanna has just dropped the link for the handbook in the chat function for people who are interested to find out more, and we can certainly circulate it after the discussion today. Vicki, you mentioned sort of building political support and buy-in, and I think that's something that a lot of advocates around the world are struggling with. I think if there was the comparatively easy answer to that one, a lot of us advocates would probably be doing something else and would be very happy at the fact that our jobs were sort of made slightly more obsolete. And so I wanted to sort of come round to each of the speakers and get your sense on actually how is it that we can start to build that political support and buy-in. So I don't know if anyone would like to jump in first, or I can pick you off at random, which I always feel very mean. But if not, then I may, Enrique, I'll come back to you to kick off. How is it that we can build that political support and buy-in, and maybe from a clinical perspective? I know you've done a lot of work with heads of hospitals and clinical services.
Yeah, so the issue of political support is certainly very important, particularly, well, this happens worldwide, but in low and middle income countries. And I want to go back to something Vicki said, which is that older adults are an underrepresented group that faces a lot of disparities. And even within older adults, there are other older adults, or specific older adults that face disparities within a disparity. So older adults from indigenous populations, older adults from racial and ethnic minorities, etc., etc. And older adults living in low and middle income countries also face additional disparities, which is that many of them do not have any type of pensions. So pensions are essential, or healthcare systems that are free. No? So while some countries have designed specific systems to protect older adults and to provide them with some care, many, I would say most low and middle income countries and all low income countries probably do not have this sort of protection. And the financial toxicity of cancer care not only affects older patients, but also entire generations, since the family needs to take care of other patients. So for me, that's one of the ways in which we can get political action. For example, in Mexico, older adults represent about 7% of the total population, yet they carry 55% of cancer-related mortality. So if you can actually show politicians that making an intervention that benefits 7% of the population would improve 50% of cancer-related deaths, the cost-benefit ratio of this is very important. So I do think that we need to generate better models of care to provide coverage for older patients with cancer, and that there are ways to do this in cost-effective manners that will end up saving money. Because, you know, politicians and management care about two things: people living longer, saving lives, and saving money. So we do need to show why these interventions actually will lead to improvements in the health of the population and to cost savings. And I'm certain that they do, not only for the government, but for families, for the patients themselves, etc. So that's one way in which I see a future for this type of policy.
Fantastic. Thank you, Enrique. And I think you raise a really interesting and a really valid point, particularly when we're looking at kind of the cost effectiveness analysis of a lot of kind of different patient-centered interventions, particularly for older adults. Obviously, a lot of those are premised on the number of years saved and the sort of DALYs and QALYs, which I think is an interesting kind of framework and may potentially disadvantage those who are maybe slightly later in life. And Vicki, I didn't know if you had anything that you might like to add to this point. I know this is something that you feel quite passionately about, so please share your thoughts.
Thank you. I get so mad when I read the comparisons of disability and adjusted life years or QALYs, all of these measures of whether an intervention is really cost effective or not. And most, for example, in HIV, if the child gets born with transmitted HIV, so it's going to have it for the rest of their life. So that skews the whole ratio. And that's not a problem. But when we start linking it with the huge volume of people who have non-communicable diseases and cancers, many of them who never get diagnoses, we get these skewed results. And I get really maddened when I think of the years that I've lost, and they don't really count, because I'm one odd individual. I'm not a group that's had a lot of money put into the measurement of it, etc., etc. It sounds very pathetic, but I mean, really, for years, at the beginning of my advocacy, this is what was thrown at me. It's cost effective to use ARVs for prevention of HIV. It's not cost effective to treat all of these people. All we can give you is primary prevention. So we continue to stop smoking, we continue to do this, but we're not going to treat any of your illnesses, because saving your leg from being cut off is not really that cost effective. It really would be doing better by giving young people ARVs. And so it's that ageism. In our country, there was a case about renal failure and the denial of hemodialysis. And that case is really ageist and needs to be challenged in our country, because it says when you're 65, you shouldn't have dialysis anymore in the public sector. You're too old and too bad. And so those are rationing decisions made based on what? And I really have difficulty with them, and they're unconstitutional in our country. Thank you.
Thank you so much, Vicki. And I think the point you raise is also a really interesting one around, you know, obviously healthcare resources are limited in every setting, and actually the way that we assess a lot of these decisions will really affect, you know, who is in and who is out. And we've kind of fairly systematically seen that older adults are more often out than in. Sorry, Vicki, go ahead.
Yeah, and so really what I also want to say is, and they don't include patients in the discussion. That's the bottom line. I mean, Enrique, you're a marvelous young man, and you're here talking with us. I'm a healthcare professional of 50 years standing. My government will not talk with the patients unless you happen to have HIV. They won't even answer our questions. And that's the kind of thing that, never mind being old or young, they don't even have anybody in there. And when it came to vaccinating, for example, they made decisions without including us and asking us. And as a result, the rollout of the vaccination campaign was really poor. We've only just reached 10%, you know, and we've been doing it for nearly 7 months or something like that. So I think until we take on this UN document, and until I think universal health coverage will not be a reality until we include the voices of the people. And that means us. It means we've got to talk, and we've got to have that agency. And for me, that's the bottom line. And let's not pretend. It's not about political declarations. It's about the people. Thank you.
Thank you, Vicki. That was beautifully fiery. And I think we should bottle you up and put you in front of quite a few of the missions here in Geneva. Jacqueline, I wanted to sort of come across to you. I know that you were saying, you know, the kind of centre to the work that your centre does is the fact that older adults are not the same, and we need to treat everyone as an individual, and actually build the services around the care that they need, require, and deserve. You know, it's a human right to be cared for. And I think one of the things I find really interesting is, within that sort of that realm of work, how is it that you've started to work with sort of the clinical teams to actually get patient voices better included in that process, and actually improving that kind of community-based care?
Sheer determination. I don't take no for an answer. My mother used to always say I had to have the last word. And I think, Vicki, we could be cut from the same cloth. We're incredibly lucky here where the local hospital works closely with us, and we have some of the oncology team actually sit on our board. So they're right in front of the patients, and they're in a position where they actually hear what's been said. I do believe we need political will. We need to shout as loud as we can to make sure the policy is changed, and that every patient, regardless, is going to get the same treatment. And I think, just looking at COVID-19, and I think this has been right across the board, everything has been thrown out and everything we have focused on is COVID-19. But people have still got arthritis, people have still got diabetes, people have still got cancer. So we need our governments to be prepared for the future and never to be caught with their pants down like they have now. And where I do think that we're in a better position for a lot of stuff in Ireland, we were still caught with our pants down. And that has to change. We need to be looking forward, and we need, again, the more holistic approach, and to actually listen to what the patient has to say. And as I said, because of our close working relationship with the hospital, it means we've had access to the consultants who actually are listening now to the patients and saying, well, look, because we go there, because we've had our counselling, because we have a support group where we meet other people, regardless of age, with the same condition, they're all learning from each other, and we now have the clinicians listening to the patient.
think that's a fabulous story, and I think it's kind of to pick up on the point you made around actually having the counselling and the support services bring together older adults and sort of multi-generations, and actually having everyone be able to sort of speak and communicate with the clinicians around what it is that's meaningful to them, what it is that they want to get out of the service, is definitely something that we can all learn from. And I think it's going to be a really key part of building sort of patient-centered care. I think one thing, sort of, we've had a few questions in from the chat, and one of the questions is actually people are dialing in from countries around the world, and it's wonderful to see the sort of diversity of services. And a lot of people are asking, well, where is it that we start? In our country, how is it that we start to kick off that work on patient-centered care, and particularly for older adults? And so, Jacqueline, I don't know if you, as the co-founder of the centre, how did you kick off the work that you were doing? You know, how is it that you've arrived here today, and what is it that you might want to share with those who are looking to follow a similar path? Oh, Jacqueline, you're on mute again. Sorry about that. You're just too polite. Your Zoom etiquette is too good.
Sorry about that. Here's the one that always wanted the last word. Okay, I looked after my mum for 9 years, and I learned very quickly that where I thought I was the best daughter in the whole world, I was, Mum would go to sweep the floor, I'd jump up, I'd take the brush, and I'd say, oh no, I'll do that. She wanted to prepare vegetables for dinner. Oh no, you sit down, I'll do that. And one day she said to me, Jacqueline, you're smothering me. And I got such a shock, and I thought, oh my God, I thought I was the best daughter in Ireland, and you're telling me I'm smothering you. But I was. And lucky enough, I actually heard what she was saying. Because as she said herself, while I'm able to do something for myself, let me do it. While I have a voice in my head, let me use it. And for God's sake, listen to me. And I think if we all follow that, and it's not rocket science, it's actually respect. It is just basic respect. And if we all have that for each other, then we can change things. But we need to listen, and we need to hear.
Fantastic, thank you for that. And maybe Enrique, sort of a similar question to you. You know, if there are budding geriatric oncologists or oncologists on the call, how is it that we can, or they can, follow a similar path in starting to build those teams and the systems and supports for older adults with care? And as a side question, how long did it take you?
Well, it takes a long time, no? So even people who work in large cancer centers in the US with a lot of support have had to do a lot of work to get geriatric oncology to the forefront. So I think that the first thing you need to do is to consider exactly what your center needs. What are the kinds of things that you can do that other people cannot do? Find that niche. I think that's the best way to begin. Find support from leadership. I think that that's essential. Finding someone who is interested in this, that is in a position of power to help you out, start developing things, and then find partners. I think that you made a great point in looking for a team. So you need to find partners who are also interested in this and who can help you. You cannot do this alone. And then you have to be patient. So be patient, be there, see the patient, work with them, and start to show the value of these interventions. It's sad that we have to do it, but we do. I mean, many people are skeptic about the role of including geriatric expertise in the treatment of other diseases. And most people around the world are still using chronological age to guide their decision making and to decide which type of treatment each patient gets. So this is work that needs to be done every day, showing the value of this. We shouldn't have to, but we need to, because if you don't do it, it won't change. And I think that everyone can do something. You don't need to have a large geriatric oncology clinic or a geriatric oncology program to start having a geriatric focus when treating your older patients and finding these partnerships within your cancer center, your hospital, your community, etc.
Fantastic, thank you for that. And I would agree that, you know, we need to chip away at this every single day, and that actually it's the people who come on that journey with us that are going to be really critical. I think sort of, Vicki, I'm going to pose the final question to you, if that's okay. What is it that you would like to see happening in the next 10 years to really drive change? We've got the decade of healthy aging that runs through to 2030. We've got 9 years. What is it that you would like to see? And I'll kick off that question with you.
Well, I think so thank you very much. It's an important one. I think we have to value what our aged population mean to our society, and that's really that's inestimable. And it's not just because I've reached this very advanced age that I didn't expect to be, but they are the people who transmit the knowledge of culture. They are the ones who tell the stories. And not only that, you know, some of us still actually work, you know, and still contribute. So I think it's valuing that and getting beyond the political speak, and not just, and the politicians need to acknowledge, and certainly in our country, that it's not just when it's time for elections that you roll out and feed all the old people in the villages. So you actually need to take care of them every day of the year. And then the final part is that old people are not just one part of their body that happens to be sick. They happen to be a person who's lived a lifetime. They know what works usually, and they know what doesn't work. And please don't treat the bits that are never going to work with a great deal of stuff, and treat the bits that can still work. I can still work because I've now got 2 prosthetic hips. Hallelujah. There was a time when I thought I was going to be in a wheelchair. So it's really about consulting and putting and working together, and you can't do it alone. And I think that's a very garbled answer, but that's what you got. Thank you.
I think it's wonderful. Jacqueline, that same final question to you. What would you like to see happen in the next 10 years to drive change? Or 9 years, potentially.
Okay, like what was said, I suppose it's a little bit like a marriage. You have to work at it every day you get up. But having said that, we need to listen to patients. We need to listen to what they want, what their needs are. We need to provide them with the best possible supports. And for that, we need all healthcare professionals, patient advocates, clinicians, institutions. We need the policymakers. We all need to work together. We need to hear what each other have to say, and we need to collaborate, and we need to support patients and promote their rights.
Fabulous, wonderful. Thank you for that, Jacqueline. And Enrique, the same question to you. What would you like to see happen in the next 10 years to drive change?
Yeah, so I would like to see aging included into cancer plans in general. Many countries guide their entire policy making about cancer based on their cancer plans, and most cancer plans do not include special provisions regarding aging. So we should change that, and I think we have the power to do that. UICC, for example, can be a leading voice in doing that, in including aspects of aging into the planning for cancer control and cancer care. And I think that's completely feasible, and that we can get that done in the next 10 years and have that as a start for each country to start building the infrastructure to provide high quality care for older adults with cancer with a geriatric focus.
Fantastic. I think that is excellent. That's wonderful. Thank you so much, guys. And it just leaves me to thank our 3 speakers, Enrique, Jacqueline, and Vicki. Thank you so much for spending the time with us today. Thank you to everyone who participated. Reflecting on the discussions that we've had so far, there are a couple of key points that jumped out to me. I think the first is that your age is just a number, and actually we really need to move away from chronology being the same as, or being the driving factor in how we treat people. There is so much behind that. There's as Vicki said, we're not just one part of our bodies. And so we need to move away from that focus on, we'll treat you this way because you've reached a certain milestone. Although congratulations for reaching those milestones. I think the second key thing that sort of jumped out to me is the importance of training doctors and nurses, building up those skills, the understanding and the respect for older adults, and particularly those with comorbidities, so that actually we can much better navigate, or patients can much better navigate the health systems that we're in, and we know that people are going to be treated with care and respect. I think underpinning so much of this is actually the need for data. We don't have very much information on the prevalence of comorbidities, for example, amongst older adults. We definitely need much stronger information systems. And I think the last point is that this is something we're all going to need to do together. This is going to need to be a really strong joint clinical patient support and advocacy journey that we go on together, and it's going to require a little bit of work by a lot of people every single day to show that we really do value older adults and those with comorbidities. And to that point, and to wrap up, I wanted to share with you all in the chat function that we have very recently released a joint report together with the NCD Alliance, the European Cancer Patient Coalition, and SIOG, so the International Society for Geriatric Oncology, just on this topic. So on aging and comorbidities and what it is that we can start to do. And so I'd invite you all to take a look at that. It'll be in our follow-up email to you all. And if you're interested in finding out more about UICC's aging work, then please do check out our website. We have a subsection on aging. There are 2 other virtual dialogues which can explore a lot more around the topic. And I wanted to extend on behalf of UICC our thanks to Sanofi for their support for our broader aging programme. And finally, thanks to everyone who's joined us today, everyone who's participated, and everyone who's posted questions. And I look forward to continuing the conversation with you all. Take care, everyone, and thank you very much for joining us.
Bye, everybody. Thank you.
Goodbye. Thank you.